Okay, class, in this section we're going to be going over caring for the patient at the end of life, and also we're going to be going over the article that I've given you, Caring for the Caregiver. In the article, some points that I felt were really important was to consider the caregivers in all aspects of care, even when in the small ways, to help them improve their patient's life. Okay. I like the statement by Rosalind Carter that said there are only 4 kinds of people in the world: those who have been caregivers, those who currently are caregivers, those who will be caregivers, and those who need a caregiver. Okay. Less than 10% of the older adults receive their care from a paid caregiver. Most of them are from informal caregivers such as family and friends. The article tells you that over 65 million individuals in the United States provide informal care, and they spend about 20 hours a week providing this care. And this is usually up on top of them having another job. This article also gives you several sources or web links for you for resources for caregivers that would help to ensure that they do not have caregiver fatigue. A lot of times these caregivers are thrust into this role without any preparation, such as if you have a patient that's had a massive stroke and they're sent home with caregivers, and they're not prepared for this, or maybe they've been in a car wreck and had some brain damage, and they're sent home with issues that the caregiver's not ready to deal with. Okay, so this article also gives you good resources for those caregivers. It lists websites where they can get some information and some support from people that are caring for patients just like they are. A lot of times it's just one piece of information that makes the biggest impact on them, and it might be a tiny insignificant thing. You need to take time to remember these caregivers are giving care, and that they need care given to them as well. And by providing care for them, that's another way for you to care for the patient, even though it's not direct care by you. Okay, now let's talk about caring for patients at the end of life. The only difference between life now and eternal life is one breath. I don't know if y'all have ever thought about that or not, but it's that final breath that you pull in that's the only difference between your life now and your life to come. It's the nurse who often has the greatest impact on the person that is experiencing death. And they have the greatest amount of experience with death themselves. You need to know and be knowledgeable about the end-of-life care, how to show compassion, advocacy, and therapeutic communications with these families. A good death is one that your book defines as being free of avoidable stress and suffering for the patient and the families, where caregivers follow the patient and the family's wishes and are consistent with clinical practices and standards. Whereas your book defines a bad death as being filled with persistent pain, wishes of the patient and the family that are not being followed, they're isolated, maybe abandonment issues, agonizing about losses associated with their death. Okay? The U.S. healthcare model focuses on the hospitals and even on some of the advanced care living and assisted living centers and long-term care centers. They do more focusing on prevention and detection and cure, and it makes it kind of difficult for care providers to accept death when they're in that mindset all the time. and acceptable outcomes to them are healing, is not death. And so they, a lot of times, will view death as a failure, and it is not. One study shows that 50% of hospitalized patients with life-threatening disease have moderate to severe pain during the last days of their lives. They didn't have their wishes met, and their wishes weren't even known in some cases. Older adults in the U.S. Estimate to account for about 75% of deaths every year, and are more likely to think about their needs and preferences at the end of life than any younger or middle-aged adult would. These older adults, they often want early discussions with their healthcare providers on their preparation for death. And despite them having this need and this desire, understanding their preferences and needs related to end of life is still lacking a lot of times with healthcare workers. Now let's talk about the pathophysiology of dying. And in it, you will see what is going on in the patho is an inadequate perfusion of body tissue. It can lead to anaerobic metabolism with acidosis, hyperkalemia, and tissue ischemia. Okay, so what's all that mean? Well, it's going to cause dramatic changes in your vital organs, and it can lead to multiple organ dysfunction. Your liver and renal system can fail also and start the dying process. When the body is hypoxic or acidotic, the heart will produce a lethal dysrhythmia, like VFib or asystole, which is going to lead to decreased cardiac output and decreased cardiac perfusion. Shortly after cardiac arrest, respiratory arrest will occur. If respiratory arrest occurs first, then cardiac arrest happens within a few minutes of that respiratory arrest. Planning for the end of life, the patient's there's Patient Self-Determination Act, the PSDA, which grants people the right to determine the medical care that they want provided for them and what they don't if they become incapacitated. Documentation of this is done on an advance directive. Advance directives, in advance directives, all states have their own forms. You need to be aware of what is used in your state. All agencies under the Patient Self-Determination Act are required to ask patients that are coming into their facility about advance directives and provide them with information and the opportunity to fill out one. An advance directive does not require legal consultation. It should be completed ideally a long time before any medical crisis arises. Now, a durable power of attorney in healthcare is not the same as a durable power of attorney for financial affairs, and you need to know the difference. Now, most lawyers, and a durable power of attorney is appointed by a lawyer, but most, or lawyer or judge, most lawyers are going to recommend that the person that has a durable power of attorney for finances and the person that has a durable power of attorney for healthcare not be the same person. The one for healthcare is designated or appointed to make decisions related to healthcare in the event the person loses their decision-making abilities. This power is not enforced to them until the physician for the patient finds that the patient has lost all capacity to make their own healthcare decisions because of an impairment to their cognition. This is going to happen when a patient can no longer receive information, evaluate that information, deliberate, and mentally manipulate that information, and communicate treatment preferences to the staff. Okay? Now, the living will is the second part of the advance directive, which tells what the patient would or would not want done to them if they were near death, such as like CPR, ventilation on a mechanical ventilator, artificial nutrition and hydration, or antibiotic therapy. Okay? The next type of advance directive is your DNR. A DNR must actually be an order from the physician or other authorized healthcare providers who instructs that CPR is either not to be attempted in the event of cardiac or respiratory arrest, or it is to be done. Okay? If you have a DNR, that means that you're not going to attempt it. By law, all healthcare providers must initiate CPR for a person who is not breathing or is pulseless unless that person has a DNR order. Be aware and know that CPR is likely not to be successful when it is performed on patients with advanced diseases, comorbidities, or if they're over 65. Most patients and their families, they don't understand the limitations to CPR, and they don't realize that that CPR actually was never intended for patients that were in end-stage disease processes. Okay? Hospice uses an interdisciplinary approach to assess and address the holistic needs of the patient and family to facilitate quality life and a peaceful death. It doesn't hasten and it doesn't postpone death, but it provides relief from the symptoms of death. Medicare hospice benefits pay for hospice services to Medicare recipients who have a prognosis of 6 months or less to live, and they agree to forego any curative treatment for illnesses like COPD, dementia, heart failure, and neurologic diseases. Early referrals to hospice care by physicians in collaboration with the healthcare team would increase its benefits for older adults and their families. However, you do not see this done very often. Palliative care is a philosophy of care for people with life-threatening diseases that assist the patients and their families in identifying their goals of care, assists them with informed decision-making, helps facilitate quality symptom management. Nurses are often in a position of assisting the patients in exploring their wishes for the end-of-life care, ask them questions to determine their advance directive status. When you're developing a plan of care for these patients near the end of death, you need to give consideration to where that person wants to die as well. Do they want to die at home? Do they want to die at the hospital, the nursing home? That type of thing. Now, collaboration in care. As death nears, you will see physical function decline, and they'll have weakness, anorexia, and changes in their cardiac and respiratory patterns, and their GI and their urinary patterns. Excuse me. Peripheral circulation decreases, causing the skin to be cool and mottled and cyanotic because they have poor tissue perfusion. Their blood pressure decreases and is often only palpable. You won't be able to hear it. You'll only be able to feel it. Heart rate may increase and become irregular and gradually decrease before stopping. They can have Cheyne-Stokes respirations, and they are pretty common. These signs and symptoms are often disturbing to the patients and the families, but they don't really cause any discomfort to the patient generally. The closer to the end of life they become, the weaker and more drowsy. They can often sleep for up to 23 hours in a day. You'll need to be able to identify alternative ways to assess symptoms and distress for these patients. You're going to teach us family caregivers what to watch for, like restlessness, grimacing, moaning, or anything like that that's noted when they occur, and what position the patient is in when they're occurring. So, in other words, is it changing positions? Is it movement? Is it medications? Is it some other external stimuli that's causing the discomfort? Note the intensity, frequency, duration, quality, exacerbating and relieving factors, and the effects on the patient's comfort when they're awake or asleep. Okay. Psychosocially, these patients may have fear and or anxiety about their impending death and experiences, and they might have some they might experience some difficulty coping with the knowledge of their death. They may differ in their needs at end of life, depending on their gender and their ethnicity. It depends on their culture also and their beliefs. Ask the family what they want to know, and if they desire the assistance of a language interpreter, if needed. Assess their culture, considerations, and values and religious beliefs, and see how they influence the dying experience. Control the symptoms and family bereavement. Your interventions should meet the needs and preferences, control symptoms of distress, promote meaningful interactions with the families, and result in a peaceful death for your patient. The coordination, interdisciplinary care, or hospice care is the most successful approach to end-of-life care. Although most perceive hospice as something as providing care for the dying, the major focus of hospice, like I said before, is on the quality of life. Pain is the most distressing and the thing that the dying person fears the most. Okay? The closer to death they are, they often lose the ability to swallow, so your PO pain meds are not going to work. They can't be crushed for the most part, especially opioids. Short-acting opioids are more quick-acting and the more effective, and they're safer to administer to the comatose patient. Okay? Pain is often underreported or undertreated. Do not withhold opioid drugs from the older adult. Reduce starting doses or make doses increases slowly, and monitor changes in mental status and excessive sedation. If they experience delirium, the pain meds can be switched from opiates to fentanyl, which does improve the delirium because it doesn't have any of the active metabolites that opioids do. As a matter of fact, patients with renal failure, fentanyl should always be used first in these patients. Provide complementary and alternative therapies like massage, music therapy, therapeutic touch, and aromatherapy to help assist with this pain management in your patients. The next slide shows you some signs of approaching death. The book gives you some common comfort measures, do's and don'ts on page 96, chart 7-1. The coolness, like I said before, of the skin is going to be due to decreased circulation in the extremities because the blood is shunting to the vital organs. Your increased sleeping and food intake, increased sleeping and decreased fluid and food intake are going to be due to decreased metabolism. Okay? Incontinence is related to perineal muscle relaxation. The congestion and gurgling is going to be due to inability to have a productive cough. They just cannot get it coughed up. Slow circulation to the brain can cause changes in their breathing pattern to make it slow and irregular, with some possible periods of apnea. Decreased metabolism and your slow circulation to the brain can also cause disorientation and restlessness in your patient. The emotional signs are withdrawal from the patient being patient preparing to let go. Okay, the vision-like experiences that they could define for you, these are not hallucinations or drug reactions. So don't deny them and don't argue with the person. You need to affirm these experiences with the person, okay? Just let them tell you what they're seeing. When they are letting go, they may become agitated due to some unresolved issues. If at all possible, find out what these are and help the patient work through to resolve these. Loved ones might need to give the patient permission to let go. A lot of times, it's not unusual to hear families saying, "It's okay, you can go now, Mama," or "It's okay, you can go now, Daddy. I'll take care of them," or something like that. It's important to the patient and the loved ones to say their goodbyes. Okay? Verbalizing sentiments can bring comfort to both the dying and to the ones that are left behind. So allow them their time to say goodbye. End-of-life care in acute setting. Why the change from curative to comfort care is so difficult. Here's you a few reasons why. Patient's and family satisfaction depends largely on the information that the patient and the family receives during their time and the way that it is provided. After the patient has died, the family may not remember exactly what was done or what was said, but they will remember how they felt at that moment. Okay, so you need to offer physical and emotional support by being with the patient and the family, respecting their cultural preferences and being realistic. Encourage the patient and the family to reminisce with each other. Promote their spirituality. Allow for those religious times. Give them that privacy. Avoid explanations of loss because it can be fruitful. Yeah. What I mean by this is, if they're asking you why, don't get into the philosophical discussion of why, because a lot of times it's just fruitless. I mean, you're going to go in circles with the family, and you might say something that one family member likes and another family member get highly offended. And it goes back to that, how they felt, not actually what they heard or what they saw. Communicate with the patient, not just the family. Remember, that patient is there until they are pronounced dead. You do not know what they can or cannot hear. A lot of times family will, what I call, talk over the patient. So if you will politely go into the room and proceed to talk to the patient instead of to the family members, they will realize a lot of times what they've done without you having to say a word about it. Okay? Refer the family to bereavement specialists if they need them. Teach the patient and the family physical signs of death so that they know what to expect. Okay? Ensure that the patient is receiving palliative care with emphasis on symptoms and management. When assessing the spiritual needs of the dying patient, consider end-of-life preferences based on their ethnic beliefs and on their practices. Be aware that supporting patients and their families within their cultural framework is essential as a part of the dying process for all patients. Respect all practices and allow for privacy during ceremonies and ritual practices. This next slide shows you the signs of death occurring. Breathing will stop, the heart will stop, pupils are going to fix and dilate, the color of their skin is going to be pale and waxen looking. Their body temperature is going to drop. Muscles and sphincters will relax, so they will become incontinent. Eyes will remain open without blinking. Their jaws may fall open. And you may hear a trickling of internal fluids in the patient's body. You need to let them all know that these are normal signs, okay, of death. Now let's talk about some post-mortem care. If the death was in the home, if it was expected, then no emergency personnel should be notified. If they are on like hospice care, you're going to need to notify the hospice program. The family members are, so that hospice nurse can go out and pronounce. If the death is unexpected or if it's suspicious, then the medical examiner is going to be notified. Otherwise, it's going to depend on your state that you're in, if it requires a physician to pronounce them dead or if a nurse is allowed to do this. Whoever pronounces death will also complete the death certificate. You need to be sure to check with your healthcare agency's policies on who's pronouncing death in that facility and the specific procedures that must be followed for that. After a patient dies, you want to ask the family or the caregivers if they would like to spend some time with that patient alone. This can help them with their coping with what has happened and to say their goodbyes to that patient. Some family members may want to bathe or to help with the post-mortem care, and this is fine. Let them do that. The body must be prepared for transfer to the funeral home or the hospital morgue. Like I said, offer this opportunity to the family if it's culturally acceptable to them. Before preparing the body, you need to find out from that physician if an autopsy is going to be required. And how you prepare the body depends on the answer that physician gives you. If an autopsy is going to be done, follow the policies about what can be done to the body and what cannot. A lot of times, if it's an autopsy under suspicious circumstances, they're not going to allow you to remove any tubes or wash the body in any form or fashion. So what you will do is put everything in the bed with the body and send it down just as is. Like I said, an autopsy is generally only performed in the event the cause of death is not known or not expected. Some religions do not allow autopsies, and you'll need to make sure that your doctor is aware if your patient is of one of these religions, such as Orthodox Jew. You need to know the chart 7-7 on page 102 on best practices for post-mortem care. And there's also a chart in your book on, let me see if I can remember what page that is on. It's table 7-3 on page 100 that gives you some of the differences as far as religions go. Okay? Now let's talk about euthanasia. There are two forms of euthanasia: withdrawing or withholding life-sustaining therapy, which used to be called passive euthanasia, and then active euthanasia. Passive euthanasia involves discontinuing those therapies that might prolong life of the person who cannot be cured by the therapy. In this situation, the withdrawal of the interventions does not directly cause the death of the patient. The prognosis of the disease and the disease process or their poor health status is the cause of death, not the withholding of treatment. Examples are like removing mechanical ventilation, antibiotics, and IV fluids. The U.S. court system also supports withdrawal of aggressive treatments and the rights of the surrogate decision maker to refuse or to stop treatments. Okay? Active euthanasia, however, requires the provider to take an action like giving a medication or a treatment that will purposefully and directly cause death. This is not supported by most professional organizations, including the ANA. Okay? Nurses should not be involved in active euthanasia or physician-assisted euthanasia. They do, however, play a major role in the end-of-life care by advocating for patients' wishes and ensuring quality symptoms management and support at the end of life. In closing, one other thing that the class that is here on campus has done that you have not done, and it will not be on your test because I have not given it to you, is a movie that is called Wit. It's a film by Mike Nichols. It is a HBO movie. It's a DVD that I was required to watch for my master's, and my master's has a concentration on end-of-life care. And excuse me, I show this film to my class, and like I said, it's not required for you, but it is something that will cause you to really stop and think about how you care for your patients at the end of their life, and how it could possibly affect them. It's a very good movie, and if you ever have the chance to get it off a Redbox or something like that, it might be something that you would want to watch. And the name of it is Wit, W-I-T. It's like I said, by Mike Nicholson, and it has Emma Thompson in it. So it's really a moving and eye-opening film. Thank you, class, for your time, and as always, if you have any questions or concerns, feel free to see me, get in touch with me, and I'll be glad to answer all your questions I can. Thank you.